Good afternoon, everyone. My name is Marcio. I will host this session, technical session number 4, that will deal with health applications of VR and AR. Thank you for the organizing committee to invite me to host this session. And let's start the presentation of the paper number 1, Proxy Haptics for Surgical Training. The presenter will be Pierre Boulanger. Pierre, it's with you.
Proxy Haptic for Surgical Training, Mahdi Rahmani, Pierre Boulanger. Learning complex surgical tasks require that novice surgeon collaborate with expert surgeon and a surgical team. To collaborate efficiency, these partners must construct a common frame of reference. The main goal of this project is to explore how proxy haptic can be used to create this common frame of reference by using props instead of complex haptic interface to be shared during a surgical procedure simulation. The application of haptic to surgical training has been researched for quite some time. Today, one can find on the market haptic-based surgical simulator for many applications ranging from minimally invasive surgery to dental procedure. Typically, users hold a surgical tool such as a laparoscope attached to a robotic arm where a force and torque sensor can be applied to sense surgeon's hand. Most of these systems are single-use and do not allow collaborative training or open surgery procedure. In order to simulate surgical procedure, the user must wear an exoskeleton device, often the shape of a glove, that can provide force to different parts of the hand or finger. Most of these systems are still in the experimental stage, and many of them do not offer tactile perception, which is critical to simulate open surgery procedure. One method for adding a sense of touch to virtual object is to use the concept of proxy haptic, where real physical props are placed around the real environment to match their virtual counterpart. If the physical props are co-registered in the virtual object, a compelling sense of tactile sensation can be achieved. In this example, a foam board was used as a proxy haptic, giving to the user the tactile perception that they were depressing a real keyboard. The proposed system used a medical-grade mannequin as the proxy haptic of a patient. The mannequin motion was tracked using optical sensor in order to be registered with its virtual counterpart. The user's hands are digitized by a non-HIVR glove, also tracked by optical sensor, which is in the same coordinate system as the head-mounted display. For these experiments, we have used the HTC Vive technology. Typical approach to register the mannequin with its virtual counterpart is to use skeleton tracking algorithm. However, skeleton tracking algorithm suffer from occlusion problem and require numerous optical sensor at the joint in order to determine the avatar joint configuration. Ideally, we would like to have only 1 or 2 sensors that can predict the motion of the mannequin joint configuration. To do so, we decided to use an inverse kinematic approach. Using inverse kinematic, one can show the joint angle of a kinematic chain by simply giving the end position and orientation of the end effector. This approach was deemed to be ideal for this application, as the motion of the mannequin arm can be fully defined by just 2 sensors. Inverse kinematic, as opposed to forward kinematic, can transform Cartesian space of an end effector to its joint space. To do so, the system must learn an inverse kinematic model that can be very complex with numerous parameters. To estimate the inverse kinematic model parameter, we have attached to the mannequin arm calibration markers at the shoulder, elbow, and wrist. We then recorded sample arm manipulation with the calibration sensor and 1 reference extra end effector sensor that will stay permanently on the mannequin head. We then optimize the inverse kinematic model internal parameter by measuring the difference between the motion prediction triggered by the reference tracker with the real motion as measured by the calibration marker. A spatial gradient descent algorithm was used to optimize the inverse kinematic internal parameter. To test our system, we did a series of experiments that allow us to confirm the following hypothesis. Our reference system is a typical HTC Vive VR setup where all the information are compared to. To validate our hypothesis, we devised 3 tasks. Each task consisted of 5 practice trials followed by 10 experimental trials. For each trial, users were told to start at a specific location. In our experiment, we had 12 participants, 8 men, 4 women. The first task consisted of grabbing the arm, moving the arm to a target, and returning the arm. We were able to see that the proxy haptic is slower than the wand used for the standard VR setup. And this is because the proxy haptic has physical constraint, and this is normal that we have a slower, we cannot, for example, go through the person. The same for all the other motion done in this task. What we observe is the same. The task number 2 was grabbing the syringe, moving the syringe to a target, moving target, and returning the syringe. We were able to observe similar thing than using the standard VR system, which means that proxy haptic is indeed slower, but more realistic because we have haptic perception associated. Last one is grabbing the arm, grabbing the syringe, moving the syringe with grabbing the arm with one hand, grabbing the syringe, moving the syringe to the target, and returning the syringe. Same thing again, we were able to observe this approximation. We also did a questionnaire testing general purpose, competence scale, system and usability scale, and believability. It turned out that 6 out of 9 prefer the proxy haptic system, and 6 out of 9 also like the HTC Vive control as a proxy for the syringe. In conclusion, the concept of proxy is working. Our results show that proxy haptic is closer to real-world action from a perceptual as well as a physical point of view. Real-world objects do not need to be resembled virtually, as illustrated by the syringe. And the concept do generalize to multiple users. In the future work, we need to more participant in more complex tasks, need to use a more reliable occlusion-free tracking technology, for example, 6D magnetic tracking. And we are in the process of performing a usability study with a collaborative surgery training for a team of 3 for a appendix removal procedure.
Okay, as our speaker is not here, I think if you have questions, please post them at WOVA system, and then the author can answer to your questions. Okay. Let's move to the next paper. Real-time approach for gait analysis using kinetic V2 sensor for clinical assessment purpose. The presenter will be Alexander de Queiroz-Burle. Alexander, it's with you.
Hi, my name is Alexandre from Voxel Labs, and I'm going to talk about a real-time approach for gait analysis using the kinetic V2 sensor for clinical assessment purpose. The human gait can indicate health issues like functional motor ability and cognitive impairments, so a gait analysis can be performed to help physiotherapists plan and monitor the rehabilitation process. And common ways to make this analysis is by using cameras, which often require markers attached to the patient's body and can be very expensive, and making a visual analysis that is susceptible to biased diagnosis. So as an alternative, it may be possible to use the connectivity sensor as a tool to perform gait analysis because it does not use markers, has a low cost, and it is portable. This research aims to create an algorithm that evaluates gait parameters in real time using just a connectivity sensor with the intent of being used in clinical environments for rehabilitation. The real-time aspect here is essential because the physiotherapist can use the Kinect along with the visual analysis during the gait. The algorithm proposed in this research was developed based on different users' gait, recorded by both a golden standard camera and the Kinect. The volunteers were placed at the beginning of a walkway and were asked to stand upright and then start walking at a comfortable pace. We used marks on the floor to predetermine the steps length and the number of steps taken by each volunteer to compare the outcomes and expected values easier. Also, 4 different setups were tested to see how the sensor inclination and distance between the marks on the floor would affect the outcomes. After the gait, the collected data were analyzed in a simulated real-time environment. And based on a questionnaire we applied to healthcare professionals, we chose to analyze the step length, stride length, number of steps taken, stance phase duration, and the angles of the hips, knees, and feet. The analysis starts by getting the joint coordinate and checking if the volunteer's skeleton is being tracked. After that, the Euclidean distance between ankles and all the kinematic variables are calculated. Then we check if a step was taken to calculate the step length, and if it's not the first step taken by that ankle, the stride length is also calculated, and this cycle happens every new frame. The algorithm correctly identified 96.8% of the steps taken during the test, and the Euclidean distance between the ankles was used to identify the steps. When there was a local maximum in the graph, it meant that the user took a step. The graph on the left shows the distance between the ankles in each frame, and the point circled in green represents the local maximum. The graph on the right is a box plot of the number of steps taken in each setup, where the green lines represents the expected outcomes for the setup. The steps length were always lower than expected, but the measurements of this variable were more precise than the ones from the stride length. In both graphs, the y-axis is the value in meters for that variable in each setup. And it is possible to see in the graph on the right that the stride length measures were accurate, but the difference between the maximum and minimum length in most setups was high. And this difference may be related to the cases of false negatives and false positive steps. When measuring the joint angles, only the hips and the knees showed acceptable results, and since the sensor does not recognize the feet well, it presented the worst outcomes. Some examples of angles for each joint during the gait are shown in these graphics, and a moving average filter was applied to facilitate the visualization of the joint's behavior. The first line contained the graphs with the better results and the second one with the worst. Each column represents a different joint. The left one represents the foot, which is calculated using the ankle joint, the middle one the hip, and the last one the knee. The algorithm often failed to identify the stance phase duration for each leg. This variable depends on the knee angles to be calculated, so it is directly affected by the algorithm to calculate joint angles. In conclusion, all the calculations could be done in a simulated real-time environment, indicating that it may be possible to obtain gait variables in real time. The algorithm to count steps worked well, the step length measurements were precise but not accurate, and the stride length measurements were accurate but not precise. And regarding the kinematic variables, only the hip and the knee angles have shown the real joint's behavior in most of the gaits. Feet angles cannot be used for rehabilitation purpose, and also the method to calculate the stance phase duration has to be improved. Thank you.
Thank you, Alexandre, for your video. Let me see if we have comments here. Have some congratulations here, but no questions. Just a second. No questions here. I have a question. We know that the device like Kinect is for home users, but do you think we can improve the data that comes from it if we use machine learning, for example, to treat the data?
Yeah, sure. In this research, we used the raw data from Connect, so we faced a lot of problems. But there are another papers that use machine learnings or different techniques to improve the joint coordinate we receive. So in future works, we intend to use some kind of filter or who knows a machine learning algorithm to improve the data we get to using the analysis.
Okay, we have a question here. Another question, a quick question. Kinect 2 has been discontinued. New RGBD cameras could present better results?
Yeah, actually, we were considering changing to the new version of the Kinect because it's for just for developers now, not for playing games, and also maybe changing to RGB cameras because there are some pose estimation papers that can help a lot in the gait analysis and identify the pose that the person is doing. So probably we will change the sensor that we use, but the method cannot depend on the sensor. You know, it has to work with every camera, and yeah.
Okay, let me see if we have another question because we have a little more time here.
Sure.
I have a second question for you. The problem you face is more because of the RGB resolution, or you feel that when the user is far from the Kinect, from the device, you have more problem than when he's near to the device?
Yeah, the Kinect has a limit distance that you can be from the sensor, so there's this kind of problem. And we know that because we used a golden camera, standard camera, to try to test the method we developed. So definitely the Kinect have some issues giving us the like precise coordinate joint. So we have to consider that in a gate maybe we will have to use more than one sensor and like use the two images to get just one image from the gate. So it's a challenge.
Okay, thank you, Alexandre.
Thank you.
Let's move to the next paper. The title is Minimizing Cyber Sickness in Head-Mounted Display Systems, Causes and Strategies Review. We can move forward. Can you play? Okay.
Hello everyone, I'm Thiago Porcino, and these are my advisors, Esteban Clua and Daniela Trevisan. Welcome to my presentation about minimizing cyber sickness in head-mounted display systems, cause and strategy review. Let's start by the introduction. So, the increase of HMD device, as well as the use of virtual reality, is linked to the high level of immersion that this device provides. This is varied for different fields, such as games, health, or scientific domains. But the problem is that systems do not offer an entirely perfect experience. In other words, this device can cause discomfort to the users. For this reason, we considered some affirmative factors such as, firstly, minimizing cyber sickness in head-mounted display systems is an unresolved challenge. And secondly, most of head-mounted displays users feel one or more symptoms of sickness. And thirdly, 80% of VR users felt discomfort after the first 10 minutes, according to Ransom. And finally, cyber sickness is still one of the biggest barrier to investment in the virtual reality content production industry. Um, from that point, our objective is to conduct a, a review of relationship analysis between leading discomfort cause and strategies that are associated to cyber sickness. So let's start by looking at this box. The discomfort can be categorized as different types of sickness by authors. VRMAS, motion sickness, game sickness, simulator sickness, and also cyber sickness. But if you look at the virtual reality box, you can see the cyber sickness category. In other words, cyber sickness is related only to virtual reality environment and also to HMD devices. So let's see, uh, take a look at cyber sickness literature review. In this section, we presented the research question of this review. First, we look to answer which are the leading cause cyber sickness cause reported in the literature. Secondly, which are the main strategies used to minimize cyber sickness. And finally, which are the used methods to measure cyber sickness in virtual reality. Uh, to, to answer the first question, we have selected from literature 10 causes from several works uh, that report different types of causes of cyber sickness, such as locomotion, acceleration, field of view, depth of field, degree of control, time exposure, latency, rest frames, rotation, and postural instability. Also, to answer the second question about strategies, we grouped about 17 strategies in 10 groups of calls. Strategies such as teleporting, slow motion, vignetting, and others. For example, teleporting is associated to a locomotion cause. It is a strategy that can minimize discomfort caused by locomotion. So let's see an example. If you look at the left, you see a normal game without any strategy. So the vignetting technique would look something like at this image at the right. The vignetting restricts the user field of view, and in this case, it's possible to observe that have more than one technique. In this case, the blurring strategy was also applied, and that means strategies can be also combined. Regarding the ways of measuring cyber sickness, the third question, we separated the most common measured ways in three groups: subjective data, objective data, and profile data. The subjective form is composed of questionnaires of discomfort, such as SSQ, VRSQ, MSSQ. Um, the objective form can be considered by the acquisition of data from equipment such as electroencephalogram, um, galvanic skin response, and heart rate. And finally, user profile facts like gender, age, experience are also relevant to relevant data to measure cyber sickness. So this work investigates the cause and solution to overcome cyber sickness. describing each current methodology. We many different methods to evaluate and identify cyber sickness caused by subjective, objective, and profile factors. And we produce a causal strategy association that summarizes this study. And finally, as a very sound step, we aim to construct a machine learning solution capable of detecting discomfort and they also identify causes and automatically suggest one or more strategies to minimize cyber sickness. Thank you for listening to my presentation. I hope you found it interesting. Now I'm ready to take the question. Thank you.
Thank you, Thiago, for your presentation. I'm sorry, I forgot to introduce you before your video. Let's see if we have questions here. If we don't have, I have one. Let me see, just a second. If you have a question, please post it on Wova, then I can see here. Let me ask you, Thiago, if it's feasible, if it's possible, is it a good idea, for example, during a user study or a real usage of virtual reality system, to ask the user or to make the user sit for a while and stand up and sit again when are playing a game or something like that? You can answer in Portuguese if you want.
Okay. Well, some works in the literature show that users tend to feel more discomfort in a standing position. On the other hand, experience with where the user is sitting tended to be more comfortable. Based in this idea, I believe if a user tends to manifest discomfort in general situation, it should be suggest to he or she participate seated. So, moreover, changing between sitting and standing position during an experience can also manifest cyber sickness generated by sensorial conflicts.
Okay, thank you, Thiago. Let's see if we have another question. Okay, so let me see here if Wova have some question for us. Okay, no. So thank you again, Thiago. Let's move to our
Thank you.
next paper. The title is Duxtopia, Conrad Prepare, Wearable AI, AR Platform for Clinical Training Emergency First Responders Response Teams. Let's play the video. Okay, just a second.
Hello, this is Dr. Japhis Doswell, and my presentation is entitled Wearable Artificial Intelligent Augmented Reality Platform for Clinical Training Emergency Response Teams. This is for SVR 2020. This is a little bit of background about myself. I have an undergraduate degree in computer science and cognitive neuropsychology, master's in computer science, PhD, IT, with many publications since 2002 in this field. And some of my research has been federally funded as well as state-based funded. Ken Wilson, Dr. Ken Wilson, has also participated on our research teams. He's a trauma surgeon at the University of Chicago and has done institutional review board research using the artificial intelligence Duxtopia system. So why is this intervention valuable? And based on our research, we've seen that for the learners, an augmented reality artificial intelligence system can decrease learning time, increase conceptual and psychomotor retention, obviating the need for a proctor during repetitive practice, and also delivering on-demand tutoring during learning and practice while performing real-time evaluation at decreased cost. For the instructors, the augmented reality system that's artificial intelligence enabled can decrease clinical procedure time, errors while performing clinical tasks, deliver on-demand and AI tutoring to EMT and paramedics, and deliver real-time performance evaluation at decreased training cost. Now, when we performed our studies, we separated the groups into experimental group and control group. The experimental group is the goggle group, the control group, no goggles. In this case, the experimental group, while performing a pressure bandage task, performed the task took longer than the control group. Same with the apply standard tourniquet. Experimental group took longer than the control group. But for the BVM ventilation, the experimental group, the time was shorter than the control group. And then the administer naloxone, just like some previous tasks, the experimental group took longer than the control group. And what we found out based on our interpretation is that for a task like BVM ventilation, that isn't a task that's readily or frequently performed by EMTs, then the experimental group were following the instructions, step-by-step instructions on the augmented reality heads-up display and performing that task faster than the control group that was trying to recall those tasks. Also, we performed various focus groups, found out that the participants, EMTs, desired shortened text for training instructions, preferred speech control, desired AI to deliver multimodal instruction. Also, they desired an augmented reality graphical user interface that was arranged in such a way not to obstruct the view of the simulator actor. And we didn't want any difficulty reading the text or information while interacting with patients. This is a graphical user interface of what the individuals would see through the Juxtopia artificial intelligent augmented reality system, and this is a needle decompression procedure. Thank you much.
Sorry, my mic was mute. As the author of this paper is not with us, we will move towards the next paper, as probably we will have some time at the end of the session, because we didn't have questions for 2 of our papers. We can have more questions at the end of the session if the audience want to make questions. Okay, let's move to the paper Low Back Pain Attenuation Employing Virtual Reality Physiotherapy. The video will be presented by Lina. Just a second. The video will be presented by Lina Panuela.
Hi everyone, my name is Lina Peñuela. I'm going to speak about the paper Low Back Pain Attenuation Employing Virtual Reality Physiotherapy, which is a part of a research project developed between the Ontario Tech University and Universidad Militar Nueva Granada. Outline, introduction, system development, study design, preliminary results, conclusions, and future work. Pain is an unpleasant sensation caused by injury, a stimulus, or it is a symptom of an illness. Around 33% of the global population suffers from the pain associated with musculoskeletal disorders, where the lower back pain has the most incidence. When it is not correctly treated, people can suffer depression, anger, have social interactions problems, the use of medications to treat the pain, and it is one of the principal causes of work absenteeism. Physical therapy is used to maintain or increase the range of movements, the force of the muscles, and to relieve pain. Sometimes people perceive the therapy as uncomfortable for experiencing pain, which makes them perform the exercises incorrectly or to abandon the therapy. VR is a technology that is being used in this area to generate more adherence to physical therapy as well as to reduce the pain perceived. Nowadays, the Oculus Rift and the HTC Vive are the most commonly used devices at the hospital. Nevertheless, non-immersive scenarios can be also used for pain relief. So the implementation of virtual scenarios for portable systems can be used outside the medical centers. We developed 3 VR exercise games for physical therapy to reduce lower back pain. The exercises selected for the environments were the quadruped arm strengthening, the pelvic bridge, and the knee to chest stretch. The exercise games were developed using Unity. To capture the user movements, we use the MPU 6050 inertial sensors, and all the exercise games have audiovisual feedback. The exercises are programmed with repetitions and frequencies according to the employed in the traditional physiotherapy exercises. First and second scenarios were non-immersive environments. The first consists of a physiotherapy lung, where the users perform the arm and leg stretching exercises following the virtual instructor who demonstrates how to do the exercise. The second consists of a balloon warehouse to perform the pelvic bridge exercise, where the execution is reflected by inflating or deflating the balloon. For both scenarios, the graphical user interface includes a timer for users to keep track on time and the score indicating when they succeed in properly executing the exercises. The third scenario is immersive. In this case, the user wears a mobile phone in a mobile VR case. It consists of a city where the user runs and dodges obstacles by executing the knee to chest exercise to move its avatar. We invited 5 participants who manifested low back pain and that have participated in traditional lower back therapies. They performed the exercises with and without the environments. Once all the exercises were completed, the participants were asked to report the pain perceived with the visual analog scale and to complete the system usability scale survey to evaluate the environments. In almost all the cases, the pain reported by the participants employing the scenarios were lower or sometimes equal to the pain reported without the scenarios. 2 participants reported higher level of pain on the first game due to more effort is required to achieve the target, and the position caused pain. The SOS scores were above 60 over 100, indicating a high degree of usability and a high probability that participants recommend to other people. In general, users perceived less pain with the environment. The environment compels the user to perform the movements with the correct ranges of motion. And as a future work, we have to customize the exercise games so that the ranges of motion are tailored to each user, and we have to test the system with more users. Thanks.
Thank you, Lina. Do we have Lina with us? Is Lina here? She was in the yeah, she was in the beginning. Here, let's see. Can you hear me, Lina? Yeah. Thank you for coming. I can't hear you. No. Victor, can you hear Lina? I can't, we can't hear you, Lina. So we will forward the questions to you, okay? From I can send you the questions to Uova. Can you try again? If you can try again, we can return to you in the end of the session as we have time. Okay? So let's move to our next paper. It's a second. It's Reanime, a neonatal resuscitation simulator for evaluating team training. Let's see the video presented by Ana Carolina.
Hello everyone, welcome to the presentation. The title of the article is Reanime, a neonatal resuscitation simulator for evaluating team training. As author, we have Ana Carolina Costa de Oliveira, João Aguinaldo do Nascimento, Sérgio Ribeiro dos Santos, Sandra Queiroz, Patrícia Carla Brito, and me, Adriana Clericuzzi. Topics. We are going to talk a little bit about the purpose of the research, how it was developed, result, discuss, and conclusion. The aim of our study is to present a virtual reality simulator in neonatal resuscitation from the interpretative analysis of the health professional at Instituto Cândida Vargas in João Pessoa, Paraíba, Brazil. To begin, we stabilized the baby was born with a heart rate below 100 BPM. After the stabilization step, we check again if the frequency is below 100 BPM. If this happens, we will go to the next step, which is positive pressure ventilation, where we ventilate the newborn in the ventilation protocol between 40 or 60 times in the interval of 1 minute. After we done the evaluation, if the frequency is below 100 BPM, intubation is recommended. After that, intubation requires a doctor, only a doctor. Other health professionals do not intubate, only doctors. Then the newborn is intubated and restart the positive pressure ventilation PPV process. We repeat and reassess. If the baby still doesn't have a frequency below 100%, it went down to less than 60, cardiac massage is recommended. So we start a cardiac massage. We repeat the massage and ventilation procedure. If the pressure is still below 60, it is recommended to medicate with adrenaline. We done this medication initially oral. If it doesn't respond, goes for invasive injection via umbilical cord. Methodology. The methodology used to develop this work was shown in the training. The training took place with health professionals in person and then simulated using Reanime. And finally, we will present the interpretative analysis of health professionals scenario. Our research scenario was the Instituto Cândida Vargas, which is a maternity hospital in João Pessoa, Paraíba, Brazil. Sample selection was non-probabilistic for convenience, and we had 16 health professionals who agreed to participate. However, to participate, they had to have taken the theoretical course about neonatal resuscitation taught by Instituto of the Brazilian Society of Pediatrics. The data collection. After the simulation training, the health professionals were asked if it was possible to learn about reanime. To analyze the answers, Iramutech was used. So, the training evaluation took place initially in person, which was carried out by a doctor from the Brazilian Society of Pediatrics, where health professionals were trained in a theoretical and practical way, and then were invited to use the reanime. Conclusion of research. The reanime has a simple interface with all the features of the resuscitation process, and it will not influence the user decision because the user will be able to make their own decision. In the end of the process, will be able to identify if is appropriate or not. And finally, we make ourselves available for questions. Thanks.
Thank you. Let me see. Carolina will ask us some questions. I will ask in Portuguese and English, and feel free, Carolina, to answer as you want.
Okay.
Do you intend to, as I could understand, you test this with professionals. Do you intend to use this with students? Você testou isso com profissionais. Você pretende testar com estudantes?
Boa tarde. O reanime foi desenvolvido com enfoque de avaliar profissionais de saúde. Mas a ideia, sim, levar para a sala de aula, para os profissionais da área de enfermagem, técnicos de enfermagem, para se aprimorar no protocolo, porque é uma sequência muito específica. Em 4 anos tem atualizações. Então, a ideia, sim, é levar, a gente tem até uma proposta agora, de um pós-doutorado para transformar isso em um ambiente EAD, né, utilizando a educação à distância, para, junto com a doutora Patrícia, a gente transformar num curso teórico e o reanime ser utilizado como uma ferramenta prática.
Ok. Deixa eu ver. Let me see if we have more questions here. Deixa eu ver se tem mais perguntas.
Ok.
Aqui.
Muito bem, Carol.
Ok. Vocês testaram durante um curso presencial voltado para este público. De reanimação.
É um curso que é desenvolvido pela Sociedade Brasileira de Pediatria, é ministrado por instrutores, e então houve o treinamento teórico, houve o treinamento prático, utilizando manequins, e a gente utilizou o reanime para a gente ver a aptidão, né? E a gente também viu que a maior dificuldade desses profissionais, muitas vezes, é aprender a sequência. Então, quando você tem uma tecnologia que pode te auxiliar no aprendizagem do protocolo em si, na sequência correta, isso pode salvar muitas vidas, né? E não é necessário, tipo, massagem cardíaca, medicação, se utilizar os protocolos corretos. De acordo com a literatura, a gente consegue visualizar que só com os protocolos iniciais, 70% dos neonatos voltam a respirar adequadamente.
Ok. Obrigado. Temos uma pergunta aqui, Gandhi Alma. Carolina, essa plataforma prevê algum nível de gamificação ou de avaliação do profissional durante ou após a simulação? A ideia de ganhar pontos, né, na medida em que eu vou resolvendo quiz?
Ainda não. A gente tem um score, eu utilizei lógica fuzzy, especialmente que a gente tem variáveis que a gente não consegue quantificar utilizando lógica clássica. Então, tem uma ferramenta internamente de avaliação de treinamento e, ao final, ele tem um score, tá? O treinamento ele acontece em 4 níveis, em 4 momentos, né? O protocolo tem os passos iniciais, tem a ventilação, intubação e, consequentemente, a gente vai para medicação, massagem cardíaca e medicação. Então, a pontuação que ele vai adquirindo em cada uma das etapas gera um score final. Então, eu, junto com alguns alunos de análise de sistema, estamos pensando em minerar esses treinamentos, né, para a gente gerar, assim, resultados mais pontuais para cada participante. Mas até o momento só gera score.
Ok, obrigado, Carolina.
De nada.
Deixa eu ver aqui se tem mais alguma pergunta. Acredito que não. Não. Então, muito obrigado. Eu vou tentar... muito obrigado pelas respostas, pelo artigo. Eu vou tentar novamente a Lina, que nós tínhamos tido um problema de conexão. I will try again with Lina, that had a problem with the connection. Let's see if we can hear her. Lina, can you talk a little bit? Let's see if we can. We still can't hear you. Let's see if people can hear you. Fatima, can you hear Lina from where you are? No? No, we can't. Sorry, Lina. We can't hear. I suggest you take a look on WOVA and see if you can see some questions there. And please, if you can, answer the questions. Thank you very much for attending and presenting your paper here. Okay, I have a request from Fatima and Rafael. Please stay here, and Fatima will tell us something. Thank you very much for attending to this session, and thank you again for inviting me to this. Fatima, it's up to you. Rafael, it's up to you.
Hi, Marcio. Thank you. We finished our first day today. So our first day of SVR today. So we want to invite you all to the social activities that we will have on Gather. So I'm sorry, I'm blocking here the link, but okay, I will show the link after I finish talking. But we will have a social activities. Basically, we will have 3 rooms. One to talk about the conference, VR, AR. So Lina, this is an opportunity for you to discuss your work with the community in this room. So maybe there your microphone will work. We have another room that we can talk about everything except AR and VR. And we have a third room that we can play electronic games over there. So it will be really fun, and I invite you all to join us in the social activities of SVR this year. We will have a lot of interesting things tomorrow. So tomorrow we have a tutorial about Vuforia and Unity. We have 2 exciting keynotes, one from James Gain and another one from Marcelo Wolf. Marcelo is from Microsoft. He worked on the HoloLens team, so it will be really interesting to see him speaking about his experience on working on the developing team at Microsoft. And also we will have a lot of interesting papers to be presented in a lot of sections like tracking, 3D reconstruction, XR applications, and we also will have the XR experience. Tomorrow, today was really great, and tomorrow will be even greater than today. So we expect to see everybody tomorrow virtually on SVR. So thank you very much for your attention. When I finish talking, the address for the social event, for the rooms to the social event will be appear on the screen. Thank you very much and have a great evening. And I see everybody of you in the social activities of SVR.
Bye-bye.
Bye.